you can see that our understanding of optimization sort of evolves as we get more information. I remember John Moe many years ago said instrumentation without fusion has 100% risk, and they all get complications. But I think we're just beginning to understand how we can help when they have these risk factors. And to show some of those examples, we go with either Brandon or Dror. Who is the next? Brandon, why don't you come? Show your first case, and we go from there. Just present the case and we can discuss.
Okay. There it is. So I have a couple to show everybody and for shared feedback. One is relatively straightforward, and the other one is a little more interesting. So I'll run up to the decision point here. This was a 1-year-old who was referred with a idiopathic appearing curve, but clearly had some developmental delays and other health problems that were still being elucidated at this point. Here's the clinical picture around 18 months of age. Child's not yet walking and has some sort of gross motor developmental delays. And here's the x-ray at 18 months. And so we decided to start treatment because the curve was at 90 degrees and this was a kyphosis scoliosis. And casting was our first initiative, which obviously didn't have a tremendous effect as expected, but was a delay tactic in a way. And then casting continued for a bit, and then the child had to have a cast removed in West Texas because they got a respiratory infection over the winter. And the plan was to come back and have another cast applied at 2.5. And meanwhile, we've got genetics and neurology evaluating the child, and there's sort of a suspected muscle disease, suspected genetic condition. And he's making some developmental milestones. He's starting to walk with the help of a walker or significant assistance. And then when he returns at 2+5, this is the clinical photo, and he's effectively emaciated. I remember the word that came to mind when I saw him before we were about to put this cast on was that he looks cachectic. And his BMI, which I'll show you in a second, or his weight for age, was somewhere between 4 and 5 standard deviations below the mean. And so we felt at this point that the deformity was probably too big to cast, and clearly the child was somewhere between underweight and malnourished. And just to highlight the social situation, this is the only guy the family could find to drive them 5 hours wearing a C-collar. That was their hired driver for the day. So here he is at 2.5. That's his weight growth chart. And I guess I've revealed what we did. But the question is, what to do about nutrition and GI in the setting of, severe scoliosis, severe malnutrition, and unknown diagnosis. And I wanted to see what resources folks utilize, how aggressive you are at nutrition, that kind of thing.
I'll stop here. Any comments?
This is a perfect indication for halo gravity traction. You got a big deformities with thoracic spine. The kid really needs a lot of support before you can undertake any sort of open intervention on him. He's the poster child for something like this. That's absolutely the right way to start.
Okay.
Anybody considers improving somehow the social aspects of
by bringing them, so we have this a lot, but by bringing him into the hospital, I can control for the next 4 to 6 weeks the social situation. So we get social services involved.
Yep.
Why was his BMI low? Does he have an ongoing GI issue, or
Well, at this point, he's still kind of idiopathic. Everybody knows there's something going on, but he's idiopathic. He does have a pretty poor social situation, so it's a little uncertain how well he's being fed at home and that kind of thing. We don't know if this is he can't absorb the calories, or he's not getting the calories, or something else. So
you can do your workup while he's a captive audience, and you can do your workup, and you can at least do an NG to feed him.
So that was my next question for everyone. So we have the ability to admit for as long as we need. I think that's, in the real world, sometimes problematic for many hospital systems. Does anybody have alternatives? If you can't admit the patient, when is it an NG tube versus a formal G tube?
Peter?
I think this is the problem that we confront the most. And a lot of these kids are very protective and really don't realize. And we've finally gotten our nutrition and GI people involved so that we can admit kids for as long as we want. And we get these kids all in to see nutrition and GI and actually let them make the decision about whether they're getting a G-tube or a G-tube. Because the complication rate of these kids with part of our thick wound infections where they're protected, and part of our problem is the part of the skin disease. So I think this is, we can't fix social situations, but you can fix this. And I think it's really good to address this.
Let me go ahead and.
Okay.
I have a question. At our center, we can keep kids as long as we want, but I find the families can't tolerate much more than 2 or 3 weeks. They say, look, I gotta get to work, I just can't do that. How do you manage the family over 6 weeks, 8 weeks, 10 weeks, those kind of things?
Yeah, really challenging. Obviously, it's easier if one of the parents can stay with the child. We've had grandparents volunteer to stay. There are rare cases where the child's sort of under, the hospital takes care of the kid and it's nursing staff and a volunteer who hangs out with the child, and the parents come and visit on the weekends. So it's obviously complex and every kid's different. This child lives 5 hours away, but fortunately the mother was unemployed, and so she was able to stay with other, and sometimes it's other siblings that have to go hang out at the Ronald McDonald House for months. This child was in house for 3 months, actually. So here's what happens to the...
How many people here are sending kids home with traction?
Yeah, and when you send them home, how often do you see them?
You've not done it yet, and I'm sort of thinking about the perfect patient. Do you wait until you're at goal weight? Any tricks from any?
Yes.
Yeah, we come from the Netherlands, and it's a very organized, small country, and we send these kids home after 1 week. We suppression to about 50% weight, and then they go home 2 to 3 months, and they come back every 2 weeks, so they go to their own hospital for the kids, for vitamin of the kids, and it's working pretty well.
What's your income here?
Depending on how the curve is reducing, if we see it's not reducing anymore, we just say, okay, let's go for surgery. If you still see some progression, we just continue. So it's not me, it's together with the rehab. They take care of the wheelchair, all the things that need to be changed, and then infection devices and stuff. So that's easy.
Yeah, and we have some patients that go home, but you have to kind of pick the family carefully, and that's a completely subjective opinion of the family. I have no way to quantify that, but you got to be careful. For this, yeah, so let me speed up. So this child was in the house for 3 months, got the weight back up, and then we went back to casting. He was 2.5 years old, still too small, I thought, at that time for growing rod instrumentation. So back into a cast for a year and returns at a year, and as you can expect, the curve is back. But so is his terrible weight. So he lost all the weight he gained while he was home with his family in the casting. So he back into traction at age 3.5. And then after another period of 3 months in the hospital, now his weight is back up to acceptable again. Here's his, kyphosis improvement in traction. And so ultimately, he went on to growing rod instrumentation, has been doing pretty well for the last 4.5 years. But here's what's interesting is when he went home after growing rods, you can see how his weight again starts to decline. And so this is the next step, was that we started to ring the bell. We had already been a little bit alarmed by the family and how they seemed to treat him and how his weight would disappear as soon as he got home. And so at this point, we had sort of notified CPS, and they went and did some assessments at home and effectively found that he was being not fed and neglected, medical neglect. So he and his siblings have all been removed. And then you can see what happens to his weight after he is placed into foster care. So it's a bit of a challenging social situation that I think frequently underlies the other problems that we are all dealing with. Yeah, he has, so for a while it was Lowy Dietz, and then that changed to, they now, based on a muscle biopsy we did when we swapped out his magic rods, he has some form of muscular dystrophy, which they think is either Ulrich or Bethlehem type. So kind of a unique kid and doing okay at this point. And here's his growth chart to show him back on track. So that's it for him. So this one's a little bit more controversial. This is a 5-year-old who was referred for progressive kyphoscoliosis, and I'm sparing you the x-rays, but there was progression of the kyphosis, progression of the rib deformity that came along with it, and here's a single shot of his brain, so you can surmise that his neurologic function is minimal. But he's been alive and well for 5 years, or at least alive, and cared for. And here is his list of dramatic medical problems. And so, the question for this child is, who, when you say call in the reinforcements, who are they? And then I'm aware of some programs, like I believe in Seattle, the adult program, they have sort of an ethical clearing board, which we don't have. And I'm curious as to, does anybody here have suggestions on an ethical clearinghouse, and how do you get a child like this who needs about 48 medical clearances?
That's what Mike was saying. Who says no?
Yeah, so we actually have an ethics board, and it's actually the folks from Dana-Farber, the cancer, has, because it's the same decisions, and it's multidisciplinary, because just like there's some kids that, that kid has more water than brain, so.
Yeah.
So,
So who makes that referral? Does the orthopedic surgeon attend that conference?
Yeah.
Is that a?
Yeah, because we call it, just like Mike said, it's like there's some patients that even though I technically do something doesn't mean I should do something.
Yep.
Makes them more smart.
Is the palliative care group in our hospital. And,
Okay.
For them, it's a little strange because they're used to leukemia or cancer patients, but I feel they've been very useful in making those decisions.
Okay, so a cancer panel and a palliative care panel instead of orthopedics.
So one of the things that we found is that in our setup, we have a MDT with all the consultants that are looking after and the family. And before that, we have a kind of proper drilling down into understanding what their aims are and clarity on the fact that the child cannot survive. And although we've lost 1 or 2 over the years, once we are a little more firm with what are we trying to achieve, are you trying to get him better, you might lose him, that's when the reality drives home, and then they say, fine, we'll work through it.
And you said MDT, who's a part of that? I think, is that multidisciplinary team? So who is that?
So that can be as complex or as simple as you want to be. So spinal surgeon, we can have the nursing staff on it, we can have the governance team on it, the appropriate medical sides of pulmonologists, pediatric neurologists, etc., and the family.
Okay.
And if required, the social services. So you can make it as simple about it, you just make it up as you go.
Okay. Any other?
Questions?
So this child came to us a few years ago, and this actually predated. We now have, thanks to Amy McIntosh, really drove our hospital system to develop a sort of multidisciplinary clearance team. And so now we have a clinic for these patients as well as older kids. That's pulmonology attends that clinic, neurology attends the clinic, and then everybody from PT, OT, child life, anesthesia attends the clinic. And so it's this child predated that, and I think he was actually one of the stimulus for that clinic. And so the family wanted treatment and opted for treatment because they felt like he was getting worse as the years went by. So he had several months of inpatient traction, and growing rods were placed. And then obviously he has lots of risk factors, and I didn't calculate his RSS, but I bet it's very high. And so very quickly fixation was lost, and he returned to the OR for the halo to be reapplied and for the implants to be sort of trimmed down. And then in the interim, while he was at home in halo, then he was found down basically in his bed at one night, and the post-mortem basically said died of natural causes related to his cerebral palsy without any comments on whether this, and this was actually sometime after his previous surgery, so unlikely to be directly related to the surgical, and more likely just his general medical condition. So we've made some changes as a result of some patients like this.
Very good, Dor. I think sometimes you find it's really difficult. Some of the information comes from the spine surgeon, but most of the time in our decision making would be between pulmonary and spine surgeon that make the final decision. Dor, come on.